I'm an interventional cardiologist at the Erasmus University Medical Center here in Rotterdam, the Netherlands. I'm hosting this virtual event together with my friend and colleague Jurgen Lichthart, who is one of our imaging specialists here in our institution already since many years. And so what we want to do today is, if we can bring up the slide set, is to bring you up to speed on how you could use your imaging and physiology tools in daily practice in order to optimize your PCI outcomes. We will do that by illustrating several cases or showcasing several cases in which we use pre and or post-procedural imaging and physiology in order to optimize our results. We do that as we do periodically internally in Erasmus, in which Jurgen typically hosts these imaging meetings we have internally, in which we discuss all kinds of cases we do. And the idea behind these meetings is always to have people learn from our experiences. And that means that not all cases we will demonstrate to you will be super slick. There will be errors, there will be things that post hoc you will find that we did not encounter during our online assessment, or vice versa. So there's always a lot of things to learn. And also for today, we prepared three cases in which we used the Navvus microcatheter as well as the HDi IVUS technology to guide our PCIs. So if we can bring up the next slide, just to give you a little bit of background. So these cases were included in the FFR React trial, in which we designed with the knowledge that the long-term risk of target vessel failure after contemporary PCI remains concerning. We also learned in the past decade that the post-PCI FFR below 0.90 is frequent and has been linked to an increased rate of major adverse cardiovascular events. And we also know that post-PCI FFR values can be increased by additional treatment. However, whether this additional optimization maneuvering improves outcome remains unknown. And with that, we designed the FFR React trial, which was a prospective single-center randomized controlled trial designed with the objective to evaluate if FFR-guided PCI optimization directed by IVUS imaging in patients with post-PCI FFR below 0.90, so those patients which we know have the highest risk of future adverse events, will improve clinical outcome with a primary endpoint of target vessel failure at 1 year. And here you see the flow chart again of the procedure. So we did our procedures per routine practice, actually with or without the use of pre and paraprocedural imaging and physiology. And then at the end of the case, we performed our physiological assessment using the Navvus microcatheter, and then randomized patients in case the FFR was below 0.90 to either control, which meant end of the procedure, or IVUS guided optimization directed by the physiology, and then we followed the patients for up to 3 years. So that said, I think we'll continue with presenting you the first case in which we used imaging and physiology to improve our outcomes. So this was a 66-year-old male patient with hypertension, hypercholesterolemia, and a family history of coronary artery disease that had a history of MI and the PCI of the LAD already 16 years ago, and the PCI of the circumflex in 2014, who currently presented with CCS class 3 angina. So this was his coronary angiogram showing you a left dominant system with a plated stent actually in the mid-LAD after all these years. Looked actually quite good. But then there was a intermediate lesion in the proximal LAD, as well as some disease distal in the LAD with a circumflex that actually looked very nicely. So with that, we started with a physiological lesion assessment. Here again, the Navvus microcatheter with which is a thin monorail microcatheter with a optical sensor technology, allowing a physiological lesion assessment over any type of routine guidewire. So that is the big advantage of this system, with the optical technology that really limits the amount of drift that you will encounter. And with the ability to do a pullback without losing wire position. I think that's a critical advantage of this product that can be used, as we will demonstrate to you, both pre as well as post procedurally. So we started here with a FFR of 0.74 and then did a pullback in which we encountered actually some gradual disease. So this is what you experience frequently perhaps in your practice, is that that patients present at older ages and more often with diffuse disease, previously stented segments, etc. And also that is something you can I think nicely appreciate in this case, is that you have multiple regions where you have a step up in FFR gradients. So the key question is what's next? And with that, we followed our, let's say, current routine practice in which we have a very low threshold to do pre-procedural imaging. And with that, we use the IVUS technology to further assess this vessel. We use the Kodama system, which is a HDi IVUS system that allows really fast pullbacks up to 10 millimeters per second. But we usually do pullbacks at 2.5 millimeter per second, which still gives you 24 frames per millimeter, which is actually very good in terms of what you can achieve in resolution. So with that, I'll pass the word to Jurgen to take you through the imaging of this LAD.
Thank you, Joost. Just explain a bit which system we use. We had to choose now this time for our Rubo viewer, where we can put in the diacoms and we can do measurements. We will start the pullback around this spot here, and I will switch this one on.
In the meantime, while the pullback is loading, one brief comment. So there is the option to post questions in the chat box. So please take the opportunity to interrupt us anytime by posting your questions in the chat box, and we will try to address them as adequately as possible.
Well, if we start here, and that's the spot that I mentioned, then we are in the distal LAD and we see an almost normal vessel, a bit intimal thickening at from 12 till 3. If we proceed with 2.5 millimeters per second, we see more proximal, we see some plaque, some fibrofatty plaque. And at a certain moment, we have around here, we have a minimal luminal area. I come back on that later. Again, a region with a normal vessel. And here we see a calcified lesion at 3 o'clock with also a smaller lumen. So as we proceed, then we reach the old stent. You can appreciate the stent struts in here, and the old stent. And we see here we have minimal hyperplasia. That's not bad. And we reach here the proximal LAD. And at the end, and this spot, we have also a smaller lumen approximately in the stent. Well, then here the pullback stopped. Well, we didn't reach the proximal LAD yet, and that's why the operator fortunately chose for a second pullback just for the proximal LAD. So there we go. So you see just the proximal LAD. It's also calcified. We have some intimal thickening in here, and again here we have a minimal luminal area, more proximal. This part we did not see yet. Here's an old stent, and here we have the minimal luminal area, and I'm going to calculate a little bit for you. And I'm going to warn you because it's not easy to read, but then if you allow me, I will read it for you. So what we do is here draw a area. We have 3.82 square millimeters and maximum diameter 2.45 and minimum 1.94 in this concentric mixed plaque. So, and if we go more proximal, we see that this vessel is diseased. There is the circumflex coming in, and here we reach the left main, which is also have already some disease in there. So if we do a summary of the whole thing, what we found now, and then we put these two pullbacks more or less together, So don't look at the frame counts, but because we took them from the 2 pullbacks. So then you see here the frame where we started in the distal LAD.
I think just to interrupt you. So for the sake of clarity, if you start doing your pullbacks, specifically with this system, it allows you 12 centimeters of pullback in one run. Always engage the IVUS catheter with the live imaging feature on, because that will allow you to position the catheter at a position where the reference lumen is, or the reference vessel segment is healthy, at least in case if you can find something. So like in this case, I think the starting point was excellent, because this first frame was recorded at the position where the vessel was actually healthy. So that really will help you at the end to get a better understanding of the length of the lesion and any potential needs for stenting, etc.
Yeah, because we're going to find some things on our way. Here, for instance, and here is the old stent, here more proximal. And here is this region with the minimal luminal area, 3.6A. I didn't do that bad, I think. And here again, there you see the bifurcation with the circumflex coming in, and the left main also with concentric mixed plaque, calcium and fibrofatty around. And that meant that
so the critical point of the first pullback is always to get a better appreciation of the type of the disease. So the morphology, if you want to call it like that, or the type of disease. Is this in-stent restenosis? Is this calcium? Is this soft lipidic plaque? And what type of lesion preparation is needed in this particular case? Second is the IVUS will allow you to make a better judgment of the severity of the disease, like for instance using a minimal lumen area. You can use it as a binary threshold. For instance, below 3 is per definition significant. If you use a value or encounter a value between 3 and 4, we say, well, then you at least have to have a plaque burden, or better, maybe area stenosis of above 70%. And I think in that case, that was in this case definitely the case, as the reference area here was well above 10, and the minimum lumen area was 3.6. So that, I think, attested to the fact that this lesion was, at least from an anatomical standpoint, significant, knowing that in this case we already had our FFR, which was well below 0.8. So here we proceeded with ballooning, trio 15 NC balloon. So we refrained, despite the calcium, from doing more aggressive lesion preparation because of the fact that there was already a stent there. We put in a new stent, the 3.526 in this case. We didn't do the measuring in this case, but with the Rupo viewer. But that is something that in daily practice, using the software that the IVUS vendor will provide to you, being it either the Kodama software or the iLab or whatever you're using in your lab, will help to very easily identify. So 3.526, we post-dilated to 22 atmospheres with a 3.515 uncompliant balloon. And then we had a result that would could be considered as satisfactory, I think, by most of the operators. And this would also mean the end of the procedure in many cath labs around the world. But this patient was lucky because he was enrolled in the REACT trial, so we actually repeated our imaging and physiology at this stage. Here you can see that the stent nicely nailed the ostium of the LAD. The bifurcation remained nicely intact, and also the circ and the left main looked, at least angiographically, very good. So as mentioned, are you finished here? Proper question. I think most of us would consider this at least as a satisfactory result. But a big advantage here is that we use the microcatheter, and we still had, of course, our wire in the LAD, and we took down the microcatheter again to do a physiological assessment at the same position and measured 0.88, which you could say, yeah.
No, there was a question.
We'll get to that in a second. So the Catheter here again showed a value of 0.88, which was well above 0.80, but also below 0.90, which is the threshold that we know that starts to get associated with adverse events. So in that case, this patient was randomized to the optimization arm, and we repeated in this case per protocol the imaging.
Well, now then let's see what we find there. So it's loading.
Well, it's loading, so there is a question. It's actually a good question as with respect to HDi IVUS in general. So we were used to have 20 megahertz technologies. Then we got the opportunity to use 40 megahertz technology, which mainly improved the near field resolution. But with that, we paid a little bit of price of penetration depth. And now with the 60 megahertz catheters, we even further increased our near field resolution, but paid a little bit more in terms of penetration depths. And these catheters actually have a hybrid imaging technology that actually adjusts between 40 and 60, giving you the best of both worlds. So 60 for the near field and 40 for the far field. So allowing you also in larger vessels to benefit from the penetration depth of a 40 megahertz catheter. At least that's how I always understood it. Jürgen, any comments?
No, that's correct. But the 60 megahertz of ACIST is a broadband because indeed, otherwise you only see the near field and you can't even reach the outside of the vessel. And so you don't have not only have 60 megahertz particles that is doing the trick, but also lower frequencies. But if you switch to 40, then indeed you can have larger vessels, because then 40 is a maximum, but then also for the far field you have also lower frequencies. So what we would suggest, if you do large cephalous vein grafts or something, or in very aneurysmatic vessels, then you can switch to 40 megahertz, and then you'll be okay. Sometimes if you have 60 in aneurysmatic vessels, then it's just a bit too short, because then you get darker images, etc., and then better to switch to 40. Yeah. Okay, then, well, this is what we have. We started distal, now a little bit on a different spot, because now we have already plugged. There is a side branch in here. And then we move up to our stent, and here is our new stent. That's the edge of the new stent. I go slowly through that. We see that there is good apposition. That means it lays against the lumen wall. But do we also have good deployment? Now, so far, it looks good. Here is the other one. And here we have also in a stent, and it's the older one, that a minimal luminal area in here, that you may say, well, we need some more deployment over here. And if we do a measurement in this.
And this is interesting, because many people will say, well, this is difficult and I cannot do that in practice. But what we've actually recently discovered, if you use OCT, the system will give you automatically the minimal lumen areas. But with IVUS, we do that with eyeballing. And what we've recently learned when we tested a extensive per frame analysis and had operators do just let's say, with eyeballing, identify the frame with the smallest lumen area, that is actually very accurate. So that I think attests to the fact that even not so experienced IVUS users will be able to easily and quickly identify the frame with the smallest lumen area.
Yeah, you need to create a little bit Carpenter's eyes.
Exactly. Exactly. But you will get better once you practice, and you will see that this sounds perhaps very, very difficult, but at the end it's not that complex.
No, you have to take some time to practice, because you cannot drive a car without learning something also.
Absolutely.
See, well, here I measured here, well, I'm sorry that you cannot read it clearly, 5.61 square millimeters. Now the interesting point is, if we go a bit more proximal than here, I leave the 5.6 here, then I will draw another line. So this is a well-deployed region. And then we have 9.4. So it's approximately 50%. And now let's see if it's about tapering. And also here, distal, we have another also good deployment. Well, now it takes blue. I cannot choose the colors, which is good, I think. There also I have, oh dear, also around 9 square millimeters. So
what you want to have is a stent that is approximately 90% expanded, but in that case, I think there's no discussion as to the fact that this stent was definitely underexpanded.
I see that if we go proximal, then we just the stent is placed over the circumflex.
And this is critical. So here you can obviously see that many of see that in many cases you either miss the ostium or have a lot of bifurcation. All right.
Okay, then the resume.
So here again, so distally, you see that so we always take again the pullback from distal to proximal. You see here distal lumen area 3.8, which is not that much, but the plaque burden, which is 48%, so that is still on the safe side. And please remember, always take the lumen area into consideration in perspective to the distal reference area. And here you can see that this vessel is actually tapering and has a healthy reference area of around 5 here a bit distally. So with that, this lesion is definitely not something that you would be willing to stent. But if we go more proximal,
here we have our distal reference more proximal, 8.53. Minimal luminal area in the stent 4.8, almost 5. And then the proximal reference 9.05, and this is actually what we measured before. And here we have the overlap with the circumflex, and this is the left main stem.
So in case of the procedural optimization with the MLA of MSA, I should say, of 4.8 with the reference area of around 9.5, we decided to do some additional post dilatation here with a 4.015 non-compliant balloon. Repeated the angio, concluded that this angiographically still looked fine. There were no signs of perforation or dissection. Now we did the imaging.
It's striking that you don't see any differences on the angiogram before your balloon.
That is a critical comment, Jürgen. I think, and that is also why we like to show these cases, because this again is a beautiful demonstration on how the angiogram can be misleading in the vast majority of cases.
Now here we are, and I think they started now more proximal in the region. Where they go? Oh, yeah, okay, there we go. Was some delay. So we start here also in the mid LAD in the spot. Here's the spot where we had 3.84 that we said, well, leave it, it's tapering. And now we go more proximal in the stent. So far, so good, but you're interested in the part where we found the minimal luminal area. And I think that was right here. Remember, a lot of calcium fibrocalcific material. So we're going to demonstrate the chiroptac's eye. And I think that here, I think it's a good spot to test our ability to measure. And I always like to calibrate every time if I start a new pullback.
So this is obviously something you need to do in the RiboViewer, which
Yeah.
Which you don't have to do in the,
No,
the imaging software.
Imaging software, you don't need it. Well, I think we, yeah, I will enlarge it a bit. Well, we have now 8.55.
Yeah,
and
that's clearly better.
Absolutely.
Yeah.
Yes, and then if we compare now to the proximal reference here, and remember that was approximately 9 when we measured. Well, here it's 11 because the now it's 11. So your balloon did also there the work, and so the maximum diameter there was 4 millimeters. So I think we achieved something here, and of course here we see that it's overlapping the bifurcation with the circumflex. Now let's see, because now you will see if we have a result with the FFR.
Yeah, so here you can see that we repeated the FFR after the improvement in the minimal standard area from 4.8 to around 8.2. We further increased our FFR from 88 to 92 by this additional maneuvering, but importantly resolved a particular part of stent under expansion, which again I think that is one of the most critical messages that we can give to you. It's one of the critical determinants of stent failure. So small minimal stent areas, and particularly if they start becoming below 5 square millimeters, the likelihood that these stents at some point will start to fail is significantly higher as compared to those with larger stent areas. So that I think is perhaps the most critical component in assessing when doing your post-PCI assessment. So that, with respect to this case, any questions, comments, please don't hesitate to put them into the chat box.
There's no open questions.
No open questions thus far. I think with that, we'll proceed to the next case.
I think so, yes.
So case 2 is a 50-year-old male patient with hypertension, smoking, who had a PCI in 2013 because of a non-STEMI with a stent in the right and in the circumflex, and in the intermediate lesion in the obtuse marginal branch, who presented now with unstable angina. This is a coronary angiogram with a diffusely diseased left system. Actually, you can see quite small coronaries with diffuse disease in the LAD and in the circumflex, but a patent stent in the circumflex. But then in the right coronary artery, you can still easily identify the culprit. So this is a long stented lesion with you see the conus, the second RV branch at 9 o'clock, where the stent starts and ends I think it's just a little bit distal to the bifurcation, if I remember correctly, with 2 spots with significant in-stent restenosis. So here we did a PCI like many of you would do in routine practice. We started with pre-dilating this lesion with a non-compliant balloon, 2.5, 15, 20 atmospheres, and dilated the whole previously stented part. Made an angio, didn't look good, and then we decided to put in another stent, in this case a 3040 drug-eluting stent, 16 atmospheres, and then given the fact that this was in-stent restenosis, actually post-dilated the full segment with a 3.5 non-compliant balloon at high pressure across again the whole segment. And then this was the final result, to which you, I think, would agree looked angiographically very nice. But again, also this patient, I think, was enrolled in the REACT trial. So we proceeded here with a post-PCI physiological assessment to at least see how the post-PCI physiology looked like at this stage, and whether it represented a value that had the potential to be improved. So we did that and found here actually a relatively good result, again, as in the previous case, with a post-PCI FFR of 0.88. With a, again, small increase distally, just distal to the bifurcation. Virtually, and this is interesting because there was virtually no increase in FFR across the stented segment. And that is interesting because typically yeah, we learned over the past years that the cross-stent gradient is linearly correlated to the length of the stent. So the longer the stented segment, the more gradient you frequently will encounter. But a gradient of 1, I think we all agree, is simply very good. But there was a gradient then again of 6 points just at the proximal part, where it angiographically actually looked relatively good. Yeah. So with that, we continued with the IVUS in order to get a better appreciation of the type of disease and to see if there could be if we were able to identify a focal target to allow post-PCI optimization.
Well, then we started in the distal right coronary artery, where what you can appreciate that is a normal vessel here. So then here we reach the old stent, and what you see here, that the old stent is underdeployed. If you compare it with the distal deployment here, it's underdeployed here, and comparing to the proximal reference, and that is so definitely this is, I'm going to measure this for you. We're going to make a measurement in here. So here we're talking about 5.18 square millimeters, 2.8 millimeters largest diameter, 2.19 smallest. And if we go distal, just to compare, you can see already with the different lines here. Then we have 6.76, especially proximal. We have 8.04. So
yep.
That's already a nice difference. So if we go more proximal, then we see here, we see even a more severe underexpansion. You see, if you compare it here, this distal, if we move proximal, then here you see the stent is compressed. And we see the stent in here, this is the old stent, and this is the new stent in there. So we have, probably due to a lot of material in the stent, we have under deployment of our new stent. If we measure this one here, then we have 3.2 square millimeters in there.
And again, so you see us measuring all these lumen areas now just for the sake of demonstration. But you will find in your routine practices that if you use imaging more and more, you really will get a carpenter's eye. So there will not be much need to, for instance, in this case, I think even without measuring the exact area, it is relatively straightforward to encounter this frame, and maybe you can show it again, Jürgen, as severe underexpansion. You see here, I mean, the lumen area should be rather consistent throughout the stented part, and in this case, it's clearly not. You can always take the catheter, which is the gray circle in the middle, which has the exact diameter of 1 millimeter. So if you keep that in the back of your head, you always have a proper reference to address the lumen area or the diameters of the segment of interest.
Yeah, then we have proximal from the old stent, because remember we did balloon dilatations. Then we see here something, and that needs often a little bit more practice. Then you see here some blood flow behind the media, indicating a submedial dissection in there. And either the dissection was there, I was looking for if we made an edge dissection, but I think that this dissection was made by the ballooning in there. And of course you can choose to cover that. And this is actually is very interesting. So if you do your post-PCI imaging assessment, you in principle look for 3 things. So one is you look at the edge,
distal and proximal, to see what is the plaque burden with IVUS. If it's above 50%, this is linked to edge disease and edge restenosis and edge restenosis related events. You look for dissections, and particularly dissections covering the media and with the length longer than 3 millimeter, and you look for expansion. And those three things you really need to remember and do at the end at all of the pullbacks, post-stenting, dissections, plaque burden at the edges, and expansion. And those three things are critical. And here, this proximal edge is actually a very challenging one, because you can see that the new stent was landed just at the exact spot where also the previous stent landed. Well, obviously, in an optimal scenario, you would have stented a bit more proximal. While this 40 millimeter stent obviously did not make that in the hands of this operator, who probably put it a bit too distal. And now we are stuck with a proximal reference segments with under expansion exactly at the edge, and a proximal edge that is diseased. And here I think drawing the circles, here Jurgen will do it manually, but the ACIST console will do that for you to give you the lumen and vessel contours to see what the plaque burden is here at the proximal edge.
Well, let's have a look. I think here we have a nice lumen and a plaque burden. So let's first see the lumen. Lumen is 7.47. That's the lumen area. Now the total vessel area. And well, just a comment you hear measuring EEM and like that. Well, measuring EEM, what you do is you measure the media, or the border of the media with the adventitia, because the EEM you cannot appreciate, you cannot see on your IVUS. So that is what they mean with measuring EEM. Well, here we have 18 square millimeters. There we have 7 square millimeters. So I think that we have plaque burden more than 50% in this case.
So this is critical. It's clearly at the edge. It's on the let's say critical side of the spectrum. So it's a plaque burden above 50%, which in theory could mean that you could consider to put in an additional stent. But obviously here the situation was a bit more tricky, because there was already 2 layers of metal here exactly at the edge, for which we had to decide first, can we optimize the proximal part, and then second to assess whether it was needed to put an additional stent here at the proximal part to cover also this part of the vessel. Another thing what you, but perhaps a bit more advanced, could consider is looking at the type of the plaque. If it's a smooth fibrotic plaque, obviously the likelihood of problems in the future would be different as compared to a plaque with a lot of fat and a thin cap, which also with a trained IVUS would be able to address.
Well, the thin cap with 60 megahertz, you can address them, because the minimal luminal the resolution is there approximately 40 microns, and what we say what we see that below 60 microns, the cap thickness below 60 microns, that we can consider as thin caps. However, it's always a bit a tricky case doing this with IVUS, and I doubt if you will do that during your procedure in the lab.
I absolutely agree with that, Jurgen. I think there should be no intent to measure cap thickness on IVUS. The resolution of IVUS is simply insufficient to do so. But what you can do is to get a, let's say, global understanding of the type of the plaque. Is that lipidic? Is that fibrotic? Or is that calcium? And in case it's fibrotic or calcified, I think you are relatively on the safe side. But if it's lipidic, like in this case, in which it's a bit of mixed plaque, you might have a higher likelihood of dissections and future problems.
Anyway, you have already a dissection. Here you see, there you see the one. Here is a room with behind the media, with which filled with blood from somewhere. Probably the opening is partly covered by your stent. And that can be the reason.
Okay, so here to to summarize,
Yeah.
Now we are desynchronized.
Yeah. Yeah, here it is. Yeah.
Yeah, so good expansion in the mid part of the stent, proximal severe underexpansion, as Jurgen demonstrated with the MLA of 3. Proximal stent has some fibrofatty plaque, as just alluded to. And here we decided to post-dilate with the 3.5 Pantera balloon up to 24 atmospheres. And then repeated the imaging.
Yeah. So that was the...
So interestingly, here we did not repeat the angio, and I think that is another advantage of IVUS, that you really use last contrast, because if you do some optimization, like in this case, of course you could do an angio, but at the end, the angio would have virtually no implications, whereas you immediately do the pullback, you save the contrast of another cine run, you save the radiation, and you get the breast imaging you have as let's say better quality imaging as when you would have done just an angio.
Now, what the operator now did is that it is very good, because sometimes people they inflate, they do post-dilatation and like that, and then they going to image only the part that they treated. But for your last IVUS, or what you think it might be your last IVUS, it's always good to have the whole picture. So that's why we started distal in this normal vessel, and that we can see all of the old stents and the new stents in there, and to see what is the situation and now if you want to do, if you need to do something more. Now here we see the part that we had a moderate expansion here, not that critical, but the interesting part was around here. And now you see that the stent in here, there is some material between the old stents, and you never remove the material. You need always room for the hyperplasia of the firmer stent, but now you see a much better expansion of this new stent in there. And I'm going to find the smallest. I think we were there already. And let's have a look. With our measurement. Time for retirement, because my 7.50. 7.50. Well, that's better than 5. So we increased with
But Jurgen, now the key question is, so we knew that this post-dilatation was going to affect the edge of the stent. So how does it look like now?
Yeah, then we have here the edge. I will remove the drawing. Yeah, here we have it. And then of course we saw the hematoma. It's in here. Sorry, it's in here. And we have here a smaller lumen proximal, and we knew already that we have a plaque burden of 60%.
Yeah.
So there's not really a big change.
So no really big change. No. So we didn't extend the dissection. There's no clear hematoma. So there's a very small rim just here at 6 o'clock maybe, but I think that is really for the expert reviewer's eye. Yeah. Jurgen, here between 6 and 9 o'clock. Do you want to allude on what is that?
6 and 9 o'clock in here.
Yeah.
Yeah. Well, this what I expect, and that's why I put already there this spot in. This I suspect that we have here some thrombus.
Yeah.
In there, and the thrombus you can recognize. Well, for thrombus, you can on IVUS, you have 3 types of thrombus that you can see on IVUS. The acute thrombus, platelet aggregation, that's rare, then you really have to be fast. The subacute, like this, and if it's pitch black or more black, then it's organized thrombus in there. Yeah. And here we have partly the subacute, I call it subacute thrombus, and more. Yeah, and also partly more organized thrombus in there. And the best thing is often to compare what we saw on the former on the former pullback. But here, this is typical. And you see that you can see a double layer of thrombus against the plaque. And what you also see that we have a straight line in here.
Yeah.
And the longer the thrombus is there, and the more it's getting organized, then it's even possible that due to blood flow, it changes shape, that you get more round shape following the lumen.
Yeah. So Jurgen, we recently, I think you already did some work on that many years ago.
Mm-hmm.
We recently redid that with the use of the HD technologies. Also with one of our fellows, Frederik Groenland, to look at the appearance of thrombi with IVUS in patients presenting with STEMI, and that was actually quite interesting. So with that, I think it would be really good also if you are starting to use or build your program on intracoronary imaging, not to be afraid to use these technologies also in patients with STEMI, because there you really will start to appreciate how irregular plaques, acute, subacute, and organized thrombi will look like. And if you take these papers, which in this case we also recently published as a reference document, you will see that you really will start to learn in how you will be able to appreciate these abnormalities.
Yeah. Well, the fun is with thrombus, if you look at the consensus papers of IVUS, everyone knows, well, they have beautiful X-rays for fibers, calcium, like that. And then with thrombus, you have almost a quarter of page, what only says, well, it could be this, it could be that, it could be such, it could be so, but you never can be sure. But I think that we tackled that also in the article, but also what we also did in a book chapter where we described also thrombus not only on IVUS but also on OCT and what is there. And there came really some interesting things. We placed together the histology and how IVUS is working, why we have things, and together with that, if you know that how IVUS is working, why it's reflecting, and then you see the histology of the thrombus, then you can understand why thrombus changes its appearance over time.
Yeah. So this again, just to remind you, is black. And black is?
Black is organized.
Black is organized. And if you see more white thrombus?
More gray.
Gray, white,
I call it subacute, just for the word. But but on histology, you see there more fibrin and more red blood cells. Actually, the lines of Zahn we found, and then because then the lines of Zahn, the fibrin and the red blood cells, that gives a reflection. But because it's also more homogeneous, it's a little reflection, so it's gray. Black, the black thrombus or the organized thrombus, you have these granulomes that eating thrombus. If you see that histology, it's a field, a very regular field, and if you have a regular field, then the ultrasound will not reflect on that. And then of course, the acute thrombus, that looks like non-moving blood. Only it's hanging on one side of your lumen, or if you forgot to give the heparin, it can hang on your catheter.
That is something you also might encounter at some point, and if you dial in more frequently to our webinars, we occasionally have these cases also as examples.
Because we have some examples there, and that later on that we said, well, why did we do this?
Okay, so that said, so this was the final IVUS imaging. In this case, the operator in this case decided not to put any additional stents at the proximal edge, but we did repeat the post-PCI physiological examination, in which, please remember, the FFR was 0.88 after the optimization maneuver, and now actually nicely increased to 0.95 with a 0 gradient across the proximal stent edge up until the ostium of the catheter. And that, to me, is another item that attests to, or at least could help you drive the decision whether or not to put additional stents in proximal areas where the plaque burden is up and about 50%. like in this case. And if there's no large dissections and no large or let's say significant pressure gradients, you could potentially decide to leave this alone. But again, of course, every case is different, and yeah, we still need to learn a lot on the individual relevance of all these individual characters. Final angio again looked very good.
And again, there is not much difference in the first angiogram.
Absolutely.
Yeah,
absolutely.
Not much.
Yeah. With that, we're making good progress here. We don't see any questions, so again, please don't hesitate to ask anything. If you want us to elaborate more or in any particular pullback or any particular segment, or if there are things that are passing by with particular segments in which you say, well, what is it I see there? Please post your questions in the chat box, and we have plenty of time to address these segments and take you through the pullbacks.
Otherwise, we earn our money too easy.
All right, good. Let's proceed to case 3, which is a 72-year-old male patient with a family history of cardiovascular disease with a MI in 1994 and the PCI of the LAD and the right coronary at that time. So again, almost 30 years ago. Now presenting with unstable angina. So this is the LAD. So again, a patient with in this case, right dominant system, some left main that looked actually quite good. The circumflex looked okayish, but relatively small at the outflow. But then you see this diffusely diseased LAD in which a routine FFR with a wire, I think, was performed, and in this case revealed a pre-PCI physiological outcome of 0.79, which was, of course, considered significant, but was not sufficient to do a exact determination of which segment actually was responsible for the patient's complaints and or jump in pressure or drop in pressure. So this operator performed a simple physiology guided PCI with only one measurement of PCI physiology, and then started treating the mid part with a 3050 non-compliant balloon. Put in a long stent, 3030 in the mid part, a longer stent in the proximal part in order to be able to cover the whole thing at once, 3.5 22 millimeter des, and then post-dilated the whole segment with a 30 and 3.5 non-compliant balloon. And with that, this was the final result. I think, again, a case that nicely illustrates that in most places in the world, this is how we do PCI. And we look at the image, say, wow, we think there is the problem. We put in 1 or 2 stents, make an angio, and it's a wow, this looks good. Thank you. Goodbye. We'll discharge you tomorrow, and you will do fine. But also in this case, we did a little more work, and we did, again, a post-PCI physiological assessment. Now, interestingly, found that the post-PCI physiology increased even by 5 points, in this case with a FFR of 0.84. But we noticed 2 things. So one here is that the gradient across the distal reference segment, in this case we took at least 2 centimeters, but in many occasions even a bit more, was almost 9 points, 9 FFR points, and we found that the cross-stent FFR gradient was 0.07, which again is I think relevant. So all the gradients we know that are above 0.05 should be considered as potentially relevant. And in this case, we have a long stented segment over 50 millimeters, in which the gradient of 0.07 was quickly recognized. So also here we proceeded with the image pullback, and Jürgen will take you through that.
There we go. So we started again in the distal LAD. We let it load. By the way, guys, this is because we report on all our imaging, and this is the Hubo viewer that we do that offline always. So here we start again in a distal LED, which is a normal vessel. You can appreciate the 3 layered.
Can you reload the case, because I don't think the people at home can.
Oh dear. Oh, Rakesh.
Maybe
Yeah, it's checking. Just a moment. Just a moment. This is, we had this once and then we lost, because we lost the connection. But no worries.
The interesting part is in this case is that you can see that again, the interest is in analyzing the full pullback. So you really start distal in this case in the LAD, and then you do your pullback. So there is no point in doing let's say, angiography guided PCI. You do a post PCI pullback, and you just image the standard segment. There's no point.
No.
You put in the IVUS catheter, you really go distally up until the point where you see the reference segment is healthy. Like in this case is I think quite well done by the operator in this case. And only then you start the pullback. And then like in this case with 2.5 millimeters per second, the pullback takes you 20 seconds to do the 12 centimeters. So there's no point in thinking you save time by only analyzing half of the pullback, because you will realize that in many cases you find out that if you review the pullback, you start in a segment like this, in which there's a lot of disease, and you have no clue what the reference segment would be in this LAD.
Now, well, here we have the first small minimal luminal area. Remember, we started a normal vessel. Well, let's do it the opposite way around. Let's make a measurement here in the normal vessel. And I'm doing this because a normal vessel often is rare, especially. So I measure always the lumen. And remember, we have 7.06 square millimeters.
Yeah.
Yes. Then we go more proximal.
So 7.0 corresponds to approximately a 3 millimeter vessel.
Correct.
It's always good to keep a little bit
yeah, indeed, it's there also. Now this is our minimal luminal area. This is more proximal. What we see here is fibrous plaque, fibrofatty plaque, but we also see a small lumen there. And if we measure this here, then we have 3.02 square millimeters.
Yeah.
Yeah.
So that tells us two things. One is that the MLA is below 0.4, or below 4 millimeters, which is a very rough binary threshold that you could use. But it's almost below 3. And at that stage, I think there's little discussion as to whether this is relevant. Also, given the fact that this reference area is 7.
Now we see also here that the vessel is, of course, diseased. The lumen is bigger. And here we have our stent. And what we also see at the stent, and that is, we were discussing this a bit also with my colleague Karen, what do we see here? It's just distal from the stent. And at the end, we decided after some discussion that indeed there must be a hematoma here outside. That we were even thinking, well, are we looking at the vein? But I doubt a bit because of the shape.
Yeah, and it's a bit in the circumflex. There's a high likelihood of encountering veins in the mid LAD. I think it's not so common, right?
No, in the mid LAD, I see the veins coming together.
Yeah,
and then walking with us, but not in this way.
No, exactly.
And then I get suspicious if it's near the edge of the stent, like we see here.
Yeah.
And I think that the source of it we can appreciate here. This is not a side branch.
No.
Yeah. So then we have here the stent.
Jurgen, we have time. Why is it not a side branch? Explain to the audience.
Oh, that's a good one. That's a good one. And that is why you make a pullback and my motorized pullback. Because then if you have a side branch, and I can demonstrate even here. Here at 11 o'clock, you see a side branch. If I move it distal and I let it run, then you see the side branch coming from far away. Look at that. There it is.
Yeah.
You saw it coming in, eh?
Yeah.
I can slow it down if you want, but here, this part here, this is not a side branch. It stays around. Eh? And it stays around for a certain moment. See? And then if we grab a bit at the edge, then here we see, and you You see the opening. And I think that's an edge section or rest of a post dilatation and filling.
But I have to admit, Jürgen, it's a little bit of an uncommon. This is not typically what you would see. Typically, you would see the dissections really with a part of the intimate media, let's say, moving around into the lumen. And also more often in areas where there is still edge disease. And in this case, the edge is the stent was actually positioned perfectly because it is in a very healthy reference segment. But still, indeed, there is...
if we can look at the angiogram again later on, if we can see something at the edge of the stent. That's... sometimes it's you even can appreciate, but I wasn't there at during the procedure. They can have extravasation. That's but this is we really had some discussion about that, but I think that we have a hematoma outside the vessel in there. Well, here's our...
But by the way, so if you think about the relevance of hematomas, at the end, what is one of the most critical items to determine the relevance is the fact to, let's say, is to address whether it's lumen comprising or not. And like if you know these patients you encounter with cath, in which the hematoma is typically luminal compromising, there you have a physiological problem because you have a stenosis caused by the hematoma. In this case, the hematoma is submedial and is not lumen compromising. So the question is this relevant clinically? Probably not.
I don't think so. It's not relevant. But I even think that it's not even submedial.
Could be,
but could be even subadventitial.
You're right.
See, and that sounds more like extravasation.
No, that is correct.
Well, here we have our stent. Well, we appreciate that it's well, if you looked very carefully, then you see here some malposition. That's this spot. I can make this moving, then you see the blood behind here. And actually, I doubt a bit if you get this ever opposed in this irregular shaped lumen, because then you need pointy balloons, and they didn't invent them. Also, ACIST didn't do that yet, but...
So this is interesting. So what you see here is this trio stent is actually, I think it's around trio. But you see this protruding luminal chunk of calcium here at 8 o'clock. Now just in the previous,
it's trio here. You see. That's so. So we see in general a good apposition. And here we see at the edge. Here we have, if Karen and I are reporting, then we always look at the shape and why the shape is there. Now, in this case, then you see definitely a smaller stent area in there, and we see a chunk of calcium pushing against the stent. We see it sometimes more extreme. Then we call this under expansion due to calcium. That doesn't mean that we have a non-sufficient lumen, because that can go together. So this is what we have. We have one minimal luminal area. We had more distal in this case, and then we talk about this region in here with a good lumen and with a big or larger reference. And I think this guy here is doing the trick with your
FFR.
With your FFR.
So here, obviously, you would use the IVUS to size the length of the stent that you would need here. We took the distal reference here, 6.7 square millimeters.
It's about 3 millimeters.
Bit back, MLA 2.5. You haven't just measured 3, but it's at least it's small. Of course, it depends a little bit on the frame you take.
There's a submedial hematoma, but we discussed now that it's possible that we have a subadventitial hematoma, but And then we have the good stent expansion, all frames more than 5 square millimeters.
Yep.
Not that we measure all the frames during the procedure, but that is what some malapose struts. I indicated them to you, but for this we need to have a pointy balloon to push them in that grate, in that cul-de-sac. Proximal reference less than 50% plaque burden. I didn't measure that for you, but
yeah, if you look at this vessel with some concentric, little bit of concentric fibrotic plaque, I think this could well be that this is below 50%. So this is something that I think that we would,
we would leave.
Well, would buy. So we proceeded here with post dilation with a 3.5 NC balloon, and then put in another stent. In this case, a 2.75 30 DES in the distal LAD.
Yeah. And that's the final result. Here the stent, here's a stent.
Yeah.
And then here we have.
And then we repeated, obviously, again, the imaging.
Now you see
so
that.
Again, this looks very elaborative, but at the end, it's not. If you have your wire in, if you would do your post-PCI physiology, obviously you need the time. If you use intravenous adenosine to wait a bit, and then you at least will take you 3 minutes to do the hyperemic assessment. Now, also with the ACIST system, you can get your diastolic pressure rate, so that is already a big advantage and saves you at least 2-3 minutes per case. With the IBIS, conversely, with a fast pullback speed, this will take you literally 30 seconds to analyze the 3 key things: the distal edge, the expansion, and the presence of dissection.
Yeah, and well, you mentioned now the time, that the less time you mean, but you have to be aware that if you want to use an IVUS, you need to take the time to watch the pictures and to do your thing. So that is once in the past. I had a survey that they showed that they asked interventional cardiologists all over the world. That was not by ACIST, but by one of the other companies. And then there was one question, and they asked, what is the most important characteristic that you want from an IVUS catheter? And I was shocked by the percentage that an answer was given to get it quickly in and out the vessel. And for these people, I have one message: please don't use it, because if that is the only criteria, you don't want to watch the pictures. And the IVUS catheter is only making pictures; it can't blow up balloons or whatever. So then, if you don't want to take the time to watch the pictures or to measurement, well, don't use it then, because then it's no use and we'll have no advantage.
I think that's a critical comment, Jürgen. And don't get me wrong. I think from a procedure perspective, doing the imaging should not be a something that is perceived as something that is difficult and takes time. I think from a procedural perspective, we really improve with these new technologies, but at the end, it's an imaging modality which only has its use if you look at the images. I think that is.
And of course, it's important that you can have quickly your acquisitions. But what I always say to you guys also, there is always you have always, if we sit here like we sit here, and like the people watching us sitting behind their desk and watching the picture there, then it's easier. But if you stand up with a patient in front of you and a screen in front of you, that's not the most ergonomic situation that you can have. And that's why I advise, if you really want to have a look, then go back, just sit back behind your registration part, and then go at ease. Just take your time to watch the pictures like that and to do your measurements. And that goes better that if you sit down during the procedure to watch that, if your patient is stable, of course, and of course you have your staff to watch over the patient, but then you can really appreciate your imaging. And then, of course, afterwards, When we look at that in the imaging meeting, you always find extra things like that. But that's
offline
always
reviewing.
exactly.
But that, I think it's again another great comment, because I think the only way to get the most out of your imaging program is to have your full staff trained. You can train yourself. You can learn how to maneuver the IVUS catheter, which is not rocket science. But at the end, the success of the procedure will lie in the involvement of the staff, the technician that is moving the cursor, as Jurgen is doing now. Because when you're scrubbed in, it's simply not that easy to scroll through all the IVUS images, and you need to learn how to talk to your technician, to learn them what is distal, what is proximal, what is the lumen, what is the vessel area, and so on. And only then you can really make this a swift and tailored approach that will help you to guide your PCIs.
And that starts with the standard protocol for all your IVUS cases.
Yeah.
Study or no study, whatever vessel it is, and
Absolutely.
start with thing.
Yeah.
And that makes really things easy.
Good.
Well, let's have a look here.
Yeah. Distal,
normal vessel. You see the vessel is small, but that's because we were deeper with the IVUS catheter now. That's if we go more proximal, then hey, there we see something that looks that we have a normal vessel, but it's much smaller. And what you also see here, that your intima is brighter, and that looks like a spasm. It has nothing to do with plaque, but that can do with a spasm, and you can resolve that often with some nitrates intercoronary. So this is not real vessel, this is spastic, and if you compare it with a normal vessel, more distal, you can appreciate also the different appearance of your intima. So, of course, there is some more disease very distally, and then also this, the vessel stays, of course, it's not a healthy vessel. And then here we have our stent. That's the distal stent, by the way. And often you have to see overlap, especially with the 60 megahertz. And I think that's for both things. Sometimes that is a bit challenging. I always calculate the length of the stent, how many frames that is, and then we can find the overlap. But for some reason, with the 60 megahertz, it's always a bit more difficult to see it in one spot. But I think that the overlap is proximally here. So here we see the proximal stent. You can appreciate that the region of malposition here that we showed.
Did it improve, Jurgen? So we had a 3.5 balloon to post dilate. We measured 3.0.
Yeah, now let's have a look. Now then I will make 3.20, 3.25.
It's a little bit improvement.
3.3 and 3.0.
Yeah.
But you see that you don't get it in here.
No.
Yeah.
No,
so
no,
whatever balloon you take, it will not. A balloon is round.
Yeah.
Yes.
Yeah.
So that's and we'll measure the and proximal. We had the calcium again, and here we're outside, no ETSA sections, and distal we didn't have any ETSA sections either. Here we have here's the spot that we want to treat, and now we see that if I see this and I compare here.
Yeah. So there is a stent, Jurgen, but we need to conclude that the lumen area didn't improve that much.
No. Let's see if we can measure this nightmare. And
so this was around 3.0, right?
Yeah, that was around 3.0. Let's have a look what we did.
2.75 stent.
2.75 stent.
So always remember, long, small stents are typically a recipe for disaster.
Yeah.
3.9.
3.9. More, yeah.
Yeah.
No.
And if you go distal?
Distal.
We had 7, right?
Yeah, we had 7.
Yeah, okay. So there's no need to redo that. So we had a distal reference of 7. So this is still significant under expansion if you would identify or define expansion as minimal stent area divided by the distal reference areas, we still would have somewhere around 60-70% expansion here, which is suboptimal.
Now see if they found that also, but this was a final result.
So that's when we repeated the physiological assessment and now measured a FFR of 0.74. So still a poor result. But please be aware of the fact that the Navvus catheter here was positioned probably a bit more distal than the initial position. But again, you can see that there is a gradient distally in this diffusely diseased distal LAD. But importantly, also a pressure gradient of 19 points across the stented segment, which is likely to be due to this underexpanded segment in the distal part. So we used, Jurgen, before you continued as a question of somebody waiting already for a bit. So we use our post-PCI physiology in this trial specifically to identify any potential areas or vessels, I should say, in which the post-PCI FFR is below 0.9 as a binary cutoff. We did a pullback, as also in this case, but used only the final FFR in order to determine whether the value was up or below 0.9 in order to determine whether or not to use imaging to improve the physiological, to improve the imaging and clinical outcome of the patient. Conversely, the question here relates to the fact, what kind of threshold would you use based on FFR alone in order to put more stents? Now, that is, of course, the million-dollar question that is currently being addressed also in the defined GPS trial, in which is an event-driven trial. I think that will enroll up to 4,000 patients, randomized to either angio-guided PCI or IFR-guided PCI using the pullback algorithm, in which you need approximately a gradient of, let's say, 5 points in order to put in different or more metal. That is a strategy that you could pursue, and is a strategy that makes a lot of sense if you have a vessel with a FFR or IFR of, let's say, 0.88 with a gradual increase, and at some point you have a really focal spot in which you identify a step up of 0.05 or 0.08 or whatsoever gradient you want to use. I think for FFR, 0.05 is a gradient that has been let's say, accepted officiously. But what we learned, and that I think is one of the critical parts we learned from the program we did with the ACIST technology, so from the FFR Search Registry, Search IVUS, now FFR React, is that the correlation between pressure gradients based on physiology and focal disease as recognized by imaging is actually not so good. So we are currently validating the individual cutoffs that have been used. So let's say 0.05, 0.03, and so on across the stent and proximal and distal to the stent, to the presence of focal residual disease as defined by IBIS, and found that there is a correlation, but it's a relatively weak correlation. So in our experience here, we really push for having a very low threshold of using intracoronary imaging in case the physiological result is suboptimal. So we hope that that answered the question. So here we are ending the end of this case, 0.074, still suboptimal. Again, a residual lesion. Healthy distal reference, but again, the stent is underexpanded. You see that with a minimal stent area is 3.4. And with that, this operator here left this case. Again, something that could be argued because the distal stent was underexpanded. But the point is that physiologically, the disease here distally was quite significant, and you could obviously argue whether you would have, if you would have optimized this stent, let's say to a minimal stent area of 5, and you still know that you have distal disease with areas of around 2.2 here where the yellow dot is, how does that physiological would help the patient is perhaps a bit arguable. But again, that's the reason we're doing these trials. We learned that if you have many operators, people work in many different ways, despite strict study protocols. And yeah, we still have to learn what type of maneuvering or optimization really helps to improve the outcome of the patient. So with that, we are at the end of our case series. If you still have any remaining questions, we would urge you to put them in the chat box. And if not, in the meantime, I would like to thank Jurgen again for his great insights in this webinar.
Always done with pleasure, you know that.
I know that. I think the pleasure is mutual, and the good thing is that because of this pleasure and the lot of joy we take from doing these things, that we made these webinars as a sort of a periodical series. Thanks to the great support of ACIST in helping us to do that, and also allowing us to have the great AV support we have here in Thorax Center. And we will be back with you, I think, somewhere in June with the next webinar.